thank you all very much for being with us today. And we are very privileged to have a very interesting speaker. I know of her work from the gesture side of things, and I associate her name with that of Janeva Velas, who many of you have probably heard of. So this is Dr. Jennifer Gerwing, who is currently associate professor at Oslo Metropolitan University in the Institute for Nursing and Health Promotion in Norway, but she is also senior researcher at Akershus University Hospital. And after, as I mentioned before, I know of her from her work in gestures, but since finishing her PhD, she has been focusing mostly on health communication. And that's why I said that we're very lucky today, because she's able to bring together those two things, the gesture studies and the health communication, which for us here at the Department of English and Communication is a privilege, as many of us are working on both sides of things. So just very quickly, in terms of admin things, if you have any questions during the talk, just write them in the chat. And at the end of the talk, we will have a few minutes for question and answer. So we'll be able to refer to those questions in the chat. And if you have any questions, obviously, after the talk, you can contact Jennifer directly as well. So I think that's everything. Just to remind you again, keep your microphones off, please. And Jennifer, thank you again very, very much for being with us, and over to you.
Thank you for such a nice welcome, Rania. It's delightful to be able to give this presentation, and I really appreciate that you invited me to speak to this interesting group of people. I don't often get a chance to talk to both people who have an interest in gesture and gestural aspects of communication, and people who are more on the healthcare side of things. And I think what I'll do, I'm just going to go along with the assumption that the audience is a bit of both. And what I'll do is just let you know that I attempted very much to design a talk that could be interesting to both groups of people. So that was a challenge that I accepted when Rania said that asked if she could invite healthcare professionals as well. So I just want to give a little bit about my background. Some of it you heard in Rania's introduction, but yes, I did spend a lot of my graduate education working with Dr. Janet Babelis in Canada. And she had a lab, a group of us who worked together to understand a little bit more about how face-to-face dialogue works. And that was her interest, to let's figure out some of the features of dialogue. And she worked with experimental paradigms. So what we would do is we would have people come into the lab, we would give them tasks to do. And because we were interested in gesture, we would test different kinds of conversational conditions and say, how does gesture and speech respond to, say, talking in face-to-face versus talking on the telephone? And then look at how does gesture respond to these different settings? Or how do people adapt gestures if they're talking about something that they have common ground with the listener? So if they have common ground, does that affect the gesture versus if they don't have common ground, if they don't have that mutual knowledge? So we had many things that we looked at in the lab to look at this, with a very special focus on how speech and gesture work together. And towards the end of my time there, we were also working with facial gestures. So I don't know if this is familiar to you, but we talk about co-speech, hand and facial gestures. So how do people use their faces with their speech to convey semantic, something to do with their meaning, and even to convey pragmatic functions in utterance. So this was my world up until I finished my PhD. And then I was fortunate enough to be able to accept employment in the country of Norway. And there I was invited to work in the healthcare setting, which if you work with language use, this is such an exciting proposition to get into such a great applied field. And what I found was a very different language about how people understood gesture and how people understood how language works. And that's a little bit how I'm going to start my talk. I want to tell you one observation that I had as a gesture researcher meeting the communication and healthcare field. I want to share one thing with you, and I think it may resonate both with the gesture people and the healthcare people. So I'll share that in a second. And then I'll use that to go on to what do we know about how patients and doctors use their hands and faces in clinical interactions. And this is from the point of view of treating these modalities as though they're integrated messages. So I'll get into the details of that. And then just to finish things off, I want to explore with you some of the implications. And one that I'm particularly interested in is if the accompanying speech is not very clear or may not be understood, what happens to the meaning of gesture? And is it still an integrated message? So I'll talk a little bit about that. So here's my observation as a gesture researcher meeting the communication and healthcare field. And I don't know if any of you have come across this, but I've had so many people say to me, did you know that 93% of communication is nonverbal? Now, if you study gesture, and especially if you study gesture like in experiments and you're used to quantification, you look at this number and you think, huh? Like what? What does that even mean? Like for me, nonverbal is just not words. So it's like everything other than the words, and somehow this is such a specific percentage and speech is only 7%. So I was quite fascinated by this. And I still have colleagues, ones who don't know me very well, will still come up and say this to me. I've seen it at conference presentations, international conference presentations. We'll start with this. So I became quite curious. What is this all about, this percentage business? And if you dig up the primary citations, so forget about books and about summary and reviews, but if you just look for the primary citations, which I did, you come across these two papers from the 1960s by Albert Moravian and two different co-authors. And these are very, very nice studies. They're experiments, very carefully controlled, very nicely designed, has nothing to do with dialogue. There's no way you can extrapolate from what they did to face-to-face dialogue. So what they did was actually presented people would come in to do the experiment, and they would be, for example, presented with a word and somebody saying the word, a recording of somebody saying the word. And then they would look at, as the participant, what attitude do they have about the person speaking this one single word based on the intonation versus what the word means. So this is a very particular situation that has nothing to do with conversation because it's just completely outside of the world of conversation. So they did a series of studies using this paradigm. Like I say, they're very well designed. And in the end, if you dig around, you find, here's those magic numbers. So what they found was the combined effect of simultaneously verbal, vocal, and facial attitudes. That's combining all the studies they did. There's this weighted sum of their independent effects with these coefficients. So this was their finding, and people have used this to say that 93% of communication is nonverbal. Now, I like to think the best of people when they mobilize this kind of information. And I think what they're trying to do, when I hear this most of the time, is tell healthcare professionals, people do important things with their tone of voice and their body when they talk. So please pay attention. And okay, fair enough. I would agree with that. I don't think it's necessary to use these experiments though, because there's 50 years of experiments on face and hand gestures that I think we can talk about instead. So I just thought that you might, as an audience, find that interesting. And if you hear that, if you hear those statistics, maybe just have a thought about where that came from. So when in my world, and most of you who study gestures will recognize, I'm going to introduce two of the grandfathers in the field, two of the biggest names in the field. One is Adam Kendon. He took an anthropological standpoint. He observed in the street, what were people doing, and videotaping very careful observations. And one of his biggest messages is that gesture in dialogue is linked to the activity of speaking, and he regarded it part of the speaker's total expression. So the gesture and the speech just go together. And even his book is called Visible Action as Utterance. So when he uses the word utterance, he would include what people are doing with their hands and bodies as part of that. So that's the one side, is this anthropology qualitative oriented researcher. And then there's another grandfather of the field who's equally important, David McNeil. And he brought gesture research into the lab. So he and his students would design experiments to look at how do people use gestures. And he said the same thing. His research and his students' research over the generations have shown that speech and gestures cooperate to express the speaker's meaning. And whereas the gestures are imagistic, so they would resemble some aspect of what they symbolize. So if I want to say, my cup of water is this big, then you can see I've made a little image for you of my cup. It matches my cup. So it's imagistically encoded, but the word cup, we would say, is digitally encoded. It's more arbitrary. So the two work together quite nicely. There's different things that you can express in gesture versus words. So with that as kind of the basic underpinning of kind of the basic fundamental assumption, if you're interested in gesture work, then let's get into this mobilizing. How do people mobilize hand and facial gestures when they're talking to each other in clinical interactions? So one of the main people who I think is very important, if this is a field that you're interested in, is Christian Heath. He, in 1986, published this book, Body Movement and Speech in Medical Interaction. And what he did was he video recorded general practice physicians or doctors in the United Kingdom talking to patients, and then figured out a very complex and interesting way of transcribing. So he had the words, but then he also had a line for how gaze function, how were people using their eyes and where were they looking. He used another line for gesture and another line for movement. So he was a conversation analyst. So very, very detailed work. And what he showed was that many examples and close analysis showing that gestures had both a depictive role, so patients were using it to demonstrate, and they were also using their gestures to seek attention. And I'll show you a nice example of that, or I'll describe an example next. And in some of his follow-up work, he talked about how patients use gestures around their body to talk about their suffering. So they could show where something hurt, like, oh, my shoulder, and they could point to the body part and show the position. They could demonstrate the scale and the type of suffering it was. And he published work on this as well. So and this is the example I'd like to share with you. I can only read it to you. I don't have video or anything, but basically what I also like about this is Christian Heath really talked about people using their whole body. So not just their hands, like when I studied gesture, we were really preoccupied with what hands were doing. but he really showed people using their whole body when they were talking to their doctor. And so in this example, it was an older woman. She had severe arthritis, a lot of pain, and she was showing her doctor how she had to move, the way she had to move her body to climb stairs at her favorite department store. So as I understand the example, I mean, she was actually standing up, like moving and used her whole body to show this. And unfortunately, the physician was listening, but he wasn't looking at her. He was turned around and writing on a prescription pad. And the way Christian Heath describes this, and I'll read this to you, is without seeing the gesture, the recipient would be ignorant of the difficulties in walking up the steps. But without listening, a viewer would be ignorant of the setting of the difficulty and even what the movements were intended to represent. So the speaker requires the recipient's participation, both as a listener and a viewer of the events. Yet as she begins her tale, she's faced with a partner who's looking at the prescription pad, writing. And in this example, what ends up happening, and it's very charming, but it shows the attention seeking. The patient actually shifted her body over into closer to where the doctor was looking, so that the doctor would be distracted prescription and start looking at her. So she actually got his gaze by moving over to where he was looking already. There's a number of follow-up studies that look at different aspects of gesture and speech in clinical interaction. Hayden and Poulsen looked at how gesture is a way for patients to externalize the experience of pain. So, of course, pain is something we feel on the inside. It's a subjective experience, but patients can mobilize that and point around their body. They can mime positions, so they can copy positions that hurt, or ones where it feels better. And they can use gestures as a metaphor, like a stabbing pain. They can use their gestures to metaphorically sort of display to the doctor. And this aligns quite nicely with what is known about how demonstrations work in dialogue. For example, Herb Clark and colleagues have talked about demonstrations as opposed to descriptions. Janet Babelis did this as well, and Charles, it comes from work back from Charles Pierce, looking at icons. These details aren't important, but the important thing is that a demonstration, if you use a demonstration, you're giving the listener something to perceive on their own. You're not describing it for them, you're showing them something. So patients show their doctors about the experience of pain. Samantha Robotham from the United Kingdom, she did, I believe this was her PhD work, because it's a beautiful series of studies that built on each other. And she looked at pain-focused talk, and basically in the first study, had people come in and describe to the researchers their experience of pain. And then they video recorded these and looked at what was gesture contributing in these descriptions, and what was speech contributing. So she used what's called a semantic feature analysis to kind of pull them apart. And again, this is very different from saying 93% of communication is nonverbal. What she was saying, what is gesture suited to represent and what is speech? And she showed this nice effect that gesture showed things like location and size, so things you can imagine, you can put into an image. But speech was so important because it showed the intensity, the effect, what caused the pain. You need words to describe when it happened and how and why. So in her follow-up work, she explored what if both gesture and speech say kind of the same thing. And she found that gesture is still conveying something unique. There's still something unique in gesture. And then she found that when people looked at the video of these descriptions versus just listening to audio, they could pick up more information from the video. They understood better. And what I didn't add here, but I think might be interesting for the healthcare providers in the room, she actually produced a 5-minute, I think it's a 5-minute video on what gestures do. And doctors who watched simple 5-minute video, we're able to pick up more information later on from descriptions of pain. So it was a beautiful line of research. Again, not authentic ones the way Christian Heath did, but a very nice application of a gesture way of looking at the world. Now, because I was interested in gesture, and before I got fully embedded in the healthcare communication field, I applied some of my gesture way of thinking to some studies. And one of the ones was I looked at what I ended up calling body-oriented gestures. So this is a type of gesture that is what I chose to call it. It doesn't use the typical taxonomy that we're used to from McNeill, say iconic or metaphoric or that sort of thing. What I looked at was what gestures do patients use around their body, and doctors. And so those what I call body-oriented gestures. And I received a very happy coincidental kind of gift of these 2 DVDs produced by Cecilia Roberts and her group in the United Kingdom. And they contained excerpts of clinical interactions that were real, authentic interactions, but we had permission to use them because they were publicly available. So what I did is I took all the excerpts off of these DVDs and gave me 29 minutes of material to analyze from 12 patients and 9 physicians. And what I found when I counted all the gestures, because that's just kind of something I like doing, but I focused on the body-oriented ones. So for patients in those 29 minutes, there were 238 gestures, and 104 of them were around the patient's body. And what they did was in speech, what patients did was they conveyed the sensation of something. So whether it was pain or lack of pain, tenderness, that kind of thing. They talked about temporal aspects, when it happened, was it in the past or the present, did it happen often? The depth of the relevant regions. So one woman talked about pain here, but she had to explain in words that it was like deep inside. It wasn't just superficial. And of course, the circumstances around injuries, you need speech to do with these, even with these gestures. Whereas, not unexpected, gestures indicated the relevant body parts and body positions, like all the research has shown so far, the direction of pain, or the direction of something. But also what was really cool was that patients would use gesture around their body to show their circumstances. So actually 2 patients drew, had something to do with the doorway in their narrative, and they drew like doors. One of them drew a door and then showed something that had happened around the door, which I consider still body oriented because it's her body relationship to the door. And another one talked about an elevator closing in front of her. So her hands became the elevator, but I was interested in the fact that it was in front of her body. So they were using gestures to do all these things. Physicians didn't use quite as many, but what they tended to do is use gesture to anchor their questions. So, you know, where does it hurt? Or like in the photo I have there, this doctor ended up using a gesture to kind of show where she was looking, which of course she doesn't need to do because she can use her eyes just to look at the patient's arm. But then she showed with her gesture exactly where she was looking and when. And doctors tended not to use speech to name body parts. And those of you who are healthcare professionals, you'll recognize that patients are really bad at naming body parts. So people will say, oh, I have abdominal pain or I have stomach pain. And the doctor kind of needs to know where you mean, because your idea of abdomen and a doctor's idea of abdomen are quite different often. So doctors would just sort of remove the issue and they would use a gesture instead to show. And beyond just the simple what did gesture and speech do, I was really fascinated with what sequences these were coming from. What were people doing in these sequences? Sometimes it was to display what was understood. So there was one where the doctor was asking about, you know, tell me more about the pain. And he just used this gesture on his chest. And the patient said, it's not pain here, it was way down here. So she used gesture to kind of fix what they were mutually understanding about where the pain hurt. And then she built on that. Another really interesting one I found was that patients used it to convey information that they didn't kind of want to put into words. So things like throwing up or vomiting, I never heard anyone say that. What they would say is, I was sick. And then they would do this, I was sick. So sick could mean many things, but the gesture shows that what the patient meant by that. Another really interesting one was contrasting, because you can do different things with different parts of your body. There was one patient that was contrasting her experience in the past with her stance towards the same thing in the present. And it was a long sequence, really, really fun to watch. So she was describing a terrible reaction to antibiotics. So she had to take these antibiotics. They made her really sick. She was one of the people who said I was sick. And she threw her body down like on the table. She was like, oh, I dreaded it, you know, and just like, but her face was smiling and laughing. So she just used her body to show two things existing at once, this sense of dread and horror of having to take this medicine, but then laughing now that she's had a little bit of distance from it, and using a little bit of a humorous tone with the doctor. So these are quite complex things that patients are doing, and doctors as well. Yeah. So then I want to get into this issue about when the accompanying speech is unclear. Because now, you know, I've talked about what the speech is conveying. And if you think about that list of things that speech is doing, what if the person doesn't understand the speech? Or what if their understanding is a little bit not perfect, or if they don't understand the words very well? So to get into this, I just want to introduce you to some terminology that I'm using, and I apologize. This is a figure that I've used from my work on emergency telephone calls. So it's a caller and an operator that I'm talking about, but it's the same idea with doctor and patient. So I like to think about, I don't like calling it something language barriers or native and non-native speakers or L1 and L2. I find all of these terms a little bit uncomfortable for different reasons. What I like to think about is the dialogue itself. What is a characteristic of the dialogue itself? Now, a dialogue can be language concordant, which means that the doctor and the patient share fluency in the same language. So if I'm at home talking to my Canadian doctor, it's a language concordant dialogue. You can also have dialogues, as you all know, that are language discordant. So that's where the doctor and the patient do not share fluency in the same language. And when you're in these situations, there's different ways that people move through the situation, which I've just listed here. So one thing you can do is just carry on in the dominant language. So for example, I might go to a Norwegian doctor and they've decided that I can speak Norwegian well enough to have an interaction with them, and we'll have the conversation in Norwegian. And then that's the dominant language. So the doctor is talking in their fluent language, and I'm talking in my not at all fluent language. It can also be that the other way around. I have before called emergency services, and I will insist on speaking English because I'm not going to describe my problem in Norwegian. And then unfortunately, the operator is forced to speak English as well. So in both of those cases, we're carrying on the conversation in a dominant language. But very often in interactions, we carry on in a lingua franca. That's another term. So for example, if there's a Polish patient talking to a Norwegian doctor, they might decide to talk in English, for example, because that's a language they're both semi-fluent in, and they're both, you know, but it's nobody's mother tongue. So that's a lingua franca. And then, of course, you can also involve an interpreter, is a way of dealing with this. And typically what I've heard, at least in telephone calls, is that they move from one to the other and into the other. So usually you try one, and when that doesn't work, you move on. So, but I'm interested in language discordance, and what does that do to gesture and gesture-speech interaction? So this is a study I did with my colleague Anna Maria Dolby, and what we did was we took from a corpus of, it was like 450 interactions. We extracted ones that were language discordant, so they were recorded in our hospital, and there was some aspect of language discordancy in these interactions. And we focused only on those sequences where the physician was describing what the patient should do in the future. So this was a very strategic choice. Because we kind of feel if a doctor's talking about what the patient's supposed to do, it must be pretty important. There's some expectation that the patient is going to be able to do this and understand it well enough to do it. So we thought that's kind of a nice place to look. And what kind of gestures are doctors using in those moments? So it ended up being, it was only eight videos, and they were 8 physicians, different physicians. And they were from all over our hospital. So there was somebody from infectious disease, urology, vascular surgery, neurology, cardiology, gastroenterology. So these were just very, very different doctors in different settings at our hospital. And I'm not getting into the details of how we went about studying this, but I thought you might be most interested in the examples. So we had a category we called semantic gestures. So these were gestures that people use to convey meaning. And those of you who study gestures, then we would say these are different from, say, beat gestures. So we were interested in the ones that were more semantic. And there was one example, the physician was suggesting movements that the patient should do to help with his muscle tension. He had huge muscle tension around his shoulders. I think he was a musician and a chef, and so he was like really tightly wound. And so the doctor was talking about, you know, sort of move. The English translation is sort of with movements of the shoulders, and he did this movement. And that was a concrete reference showing the action that the patient should do. And indeed, in that little moment in the sequence, the patient copied the gestures and did them as well. In another example, and this one was a really interesting example. I think we've written about it a couple times actually, because it was a physician talking about, he wanted the patient to do a liver biopsy, to go get a liver biopsy done. And it was really unclear whether the patient was understanding what was happening. And he did a whole series of gestures, the physician, and I have to sort of sit up to show you, but he pointed like this to his side, the physician did. And at one point even made a little needle with his finger and like pointed to his side. And he was like referring in this example where he said, you remember that? You got a needle in you. He's referring to a biopsy the patient had in the past. But then he would use sort of the same gesture to say, I want you to get a liver biopsy. But it was like the same gesture. So that was another sort of semantic gesture. Another one, this was a more, we looked at concrete and abstract gestures. And this was one where the doctor was talking about the patient's viral levels. She had HIV and she wanted to become pregnant. And he wanted, part of the conversation was she should wait a little longer. And he said, I thought we could come into kind of a quiet phase where it was down all the time. So he used this metaphor for this quiet phase. Sorry to throw so many examples so quickly at you. I want you to get a sense of all these different kinds of ways people use gesture. Another one, very simple, the physician was describing what the medications do, and she talked about Immorel and prednisone are such drugs that we give to reduce inflammation. And she did this gesture like this while she said that. And the same doctor talking about the quiet phase, he wanted to really drive home the point, the lower the virus levels, the lower the risk. And he used a gesture to point to one place in space and another place in space. So these were two things: the lower the virus, the lower the risk. Now, think about this. These are all gestures that are depicting for the patient things they should do in the future. And they all have a function of trying to enrich the understanding well enough that the patient will be motivated and able to do these things. So one patient's supposed to do some exercises of a certain kind. Another patient is supposed to agree to have a liver biopsy taken. You know, another one is supposed to be patient enough to wait to get pregnant. So these are all like kind of important things that the doctors were using these gestures to help to depict. And what we sort of found when we really thought about this a lot, about what was happening, because these patients didn't always speak, they had various Norwegian levels that were not always matching the level of the doctor. And what we really felt was that if the speech was not understood, the meaning conveyed by the gesture would be ambiguous. So if you don't really understand the speech and you see the doctor doing this, is this something you're supposed to do? Or is it something you're not supposed to do? And when are you supposed to do it? Like, so those kinds of questions. And then with the liver gesture, okay, there's the liver, yes, I understand, and there's the needle, but what's relevant about that? Are we just talking about my medical history, or are we talking about something in the future? And these are things that can be conveyed in kind of you know, complex syntactic structures. Tell us that information, and if the patient doesn't understand, then it's and really that particular liver biopsy interaction ended after quite a long time, with deciding that the patient had not understood well enough and they should call an interpreter next time, because the doctor could not get a signal from the patient that he'd understood what this plan was. Although I think, if I remember correctly, the patient copied the gesture and nodded quite a lot. He remembered that liver biopsy and he said it was painful. So he did remember it, but it wasn't clear that the message was understood about getting a new. And just to close, and I think this is nice, I'll be able to finish soon enough that we can have a discussion. If you'd like to ask me some questions or bring up some points, I would really, really love to hear what you think of some of this. But I thought to finish, why don't we stick some of these gestures into context? What did the sequence look like that they came in? So here's an excerpt with the patient response to the gestures. Now, in this excerpt, there was a cardiologist, and he was explaining something a little bit complicated. The patient had come in with heart palpitations, and they had to. You could see over the course of the dialogue, this gesture became those palpitations, and the doctor was trying to explain, like, she had her dosage she was supposed to take, but she could take a little bit more. So, so he said, but use a half. He said, the point is, if you get this very often, and just as he said often, and notice he's not through, if you get this very often, she said, oh yeah. And that, I mean, you can see that he's not finished with the message, but oh yeah is a very strong sign of understanding. So this was a little bit confusing. And then he said, then you can take one tablet of those. And as he said of those, she lifted up her finger as well, one tablet. And she finished that utterance with one tablet a day. So you can see from that response, she's not picking up this contingency between, if you feel this, you can take one full tablet. these things are tied together. This is an important message from the cardiologist. And her responses were really, didn't indicate that she understood. And he finished, but then you have to talk to your physician first. And so when we say we are speculating, my co-author Anna Maria and I, we were merely speculating when we said that patients might not understand the message. But that speculation was based on sequences like this, where we would see patients respond very quickly to the gestural component. So as soon as he did that, she was like, oh yeah. It was like maybe she was indicating she understood what they were talking about, but the message wasn't finished. And when he said 1 tablet and held up his finger, she immediately indicated understanding of that. But then immediately her response, 1 tablet a day, suggests that she didn't understand. And this was, if I had $1 million and all the time in the world to study gestures more in this context, I would love to see what's happening in language discordant dialogues. Are gestures mobilizing a quick response from the patient that may be a misleading sign of understanding? And in both of these cases, the doctors kind of picked up that things were not fully understood, even though they were getting responses from the patient. So in all of these cases, the physicians were conveying essential information. He used gestures that conveyed information, and those gestures were easier for the patient to grasp than his speech. But the meaning of the utterances depended on the speech. So hence the meaning of gesture depends on the speech. And the timing of her responses was immediately after gestures in the middle of his utterances, which created some confusion. So in conclusion, if we go from my observation as a gesture researcher meeting the healthcare communication field and my sense of confusion about what 93% of communication is nonverbal, just unpacking that a little bit. Instead, I would say there's a nuanced interplay in the timing and the meaning, what patients convey in their hand and facial gestures and in their speech. And when these things come together in an utterance, the meaning is mutually dependent. So in healthcare communication, I find again and again, these nuances are often overlooked and they're not well studied. I see people listening, using audio recordings for video, for face-to-face interactions. And they say, well, we won't see the gestures, but that's okay. It's kind of like, we don't really need the gestures. The speech will have all the information we need. And I think, well, yeah, but the meaning of the speech depends on what people are doing at the time. So it's a tricky question. And I think in healthcare communication, I don't see a lot of people really understanding the nuance of this. And then when people are talking, when doctors are talking to a patient, they're not sure if the patient is understanding. Gestures give this sense of security. I see it's like a lifeline, like the doctor will use a gesture and suddenly the patient, there's a spark of oh, I get it, so they're quick to catch the life preserver that gesture gives them. But I think that that's a bit of a risk because I think that you can easily overestimate how much people are understanding based on that. So with that, I'll conclude. I've got my email addresses there. You're very, very welcome to contact me if you have any follow-up questions or ask me about any of the work cited. And we have plenty of time now, Rania, if anyone would like to ask some questions.
Thank you so much for a fantastic talk. Really, really interesting.